Chapter 29, The Child with Endocrine Dysfunction. In this chapter, we're going to be looking at our endocrine glands and looking at both too much and too little of the hormones that they secrete. So we're starting with hypopituitarism, and we're going to talk about too little growth hormone secretion. So deficient secretion of growth hormone. The treatment is to replace that growth hormone. This is a child who's not growing normally, or if it's not caught soon enough, they'll have delayed puberty. So because they have deficient growth hormone, the treatment is to replace the growth hormone. And 80 to 90% of the time, this is successful. If we can give them growth hormone, we can get them up to a normal range of height. They're not going to be tall, but we can get them to within the average. And it's given as an injection once a day at bedtime, and the problem with it is that it is very expensive. Now we keep giving it until we know those bones have no more growth left in them, and remember, we can tell that by looking at the x-rays of the hands and looking at the growth plates, the epiphyseal of the bones, and when those are closed, there's no more growth left, then we stop giving the injections. Oftentimes these kinds of problems go together. There may be a tumor on one of the endocrine glands, or there's been a trauma to it or something. So sometimes we're not talking about an isolated hormone that's off. So we would need to look at the other hormones and see how this child's doing, if there's anything else we need to correct or replace. Now if we have hyperfunction of the pituitary, this is too much growth hormone, and we're going to get overgrowth of those long bones. After the epiphyseals have closed, if there's continuing growth, I have some pictures to show you what we'll see as that continues past the bones being done growing. These people are way outside of normal height. We're talking about 8 feet or more. And then I'll show you that acromegaly. I've got a picture of that. That's after the long bones are done. So the treatment is to find out what's stimulating the pituitary gland to do all this secreting of growth hormone and stop it. Usually it'll be a lesion on there. And so we would either irradiate it, or they can put in radioactive implants that destroy some of the tissue to, if you have less pituitary tissue, you're going to have less pituitary secretion. Here's a picture. You get this really elongated face. The jaw has continued to grow. That actually, you get malocclusion of the teeth, so it has some problems with eating. And you can see his feet as well, that continued growth of the bones. You get not only that amazing height, but some odd shape to other things. Okay, precocious puberty. This is when kids show the secondary sex characteristics for girls before the age of 8 and for boys before 9. Usually, most of the time, we don't find a cause for it. It may have run in the family. We may find out that a parent or aunts, uncles had the same thing. We can stop this. We can use a monthly injection of Lupron, and that will slow down the changes, the pubertal changes, and let this child have a little longer childhood. Diabetes insipidus. This is the posterior portion of the pituitary, which remember, it secretes ADH, antidiuretic hormone. Well, diabetes insipidus is hypo, so not enough secretion of antidiuretic hormone. And just like that sounds like, that means we're not stopping diuresis, we're allowing it to happen. So uncontrolled diuresis. These kids pee and pee and pee and pee and cannot concentrate their urine. They just pee a lot. Because they pee so much, they are thirsty. They're constantly needing to replace those fluids that they're peeing out. So they're going to drink and they're going to void. We do need to be careful about dehydration. They can't concentrate their urine, so we need to make sure they are drinking enough. We do let them drink as much as they need. The signs and symptoms are the polyuria and polydipsia. The treatment, we can do a hormone replacement of vasopressin, and this is either can be given sub-Q or can be given in a nasal spray. The nasal spray is usually once a day. The sub-Q has a little longer life. I believe it's every 48 hours or so. When I've seen diabetes insipidus, it's usually after a head trauma or brain surgery. So anything that changes pressures in the brain and puts pressure on that posterior pituitary can trigger this. Some kids it just is. It's not always going to be after some sort of head trauma. Now the opposite is hypersecretion from that posterior pituitary of ADH. So that's going to make these childs retain fluid. As you retain fluid, think of that as holding in water. The sodium that you have in your blood, we're now adding in lots of water and diluting it. So you're going to see a low sodium level. Some of the signs and symptoms: anorexia, nausea and vomiting, irritability. You can get personality changes too. We need to treat whatever the underlying condition is that's causing this, but the first thing, the immediate thing we're going to do is restrict their fluids, because they're not peeing, so we don't want to give them any fluids. And realize if they're not peeing out potassium, so we would want to make sure they're not getting potassium. Okay, juvenile hypothyroidism. This can be caused by a number of different defects, but basically this is hypo, so we've decreased the secretion of thyroid hormone. And remember, your thyroid hormone affects metabolism. So we've got lowered metabolism in an infant where their brain is still growing and those neurons are making multiple connections, more synapses. We've got to get treatment quickly, or we're going to see a lot of developmental delay in these kids, mental retardation. If it's an older child, then we're not so worried about mental retardation happening, because most of that brain growth and the increasing complexity of synapses and connections in the brain is pretty well complete by 2 to 3 years. So that's not, I mean, it's still a concern, but it's not the level of concern as in an infant. The treatment is to give them oral thyroid hormone. We're going to replace that hormone because they're not secreting it. Now the opposite would be too much, hyperthyroidism. This is also called Graves' disease. This usually comes from an enlarged thyroid gland. You're going to see this exophthalmos, which is protruding eyes, bulging eyes. I have a picture of that coming up. You're going to see hyperactivity. Remember, they've got increased metabolism, so they've got jittery, agitated, just movement. This is caused by thyroid stimulating immunoglobulin in the serum. We can treat it. The treatment's kind of controversial of which to do. There are some anti-thyroid drugs that we can give. We can take out that thyroid gland that's not working, in which case then we would have to give them thyroid hormone, because if we take it out, if we take out less than all of it, just a subtotal take out part of it, hopefully we leave enough that we don't have to replace thyroid hormone. Or we can do an ablation with radioiodine. Iodine goes to and settles in the thyroid gland. So if we do radioactive iodine, it will go, settle in that thyroid gland, and then destroy some of it. Again, our hope is that we can destroy enough that we don't have the hyperthyroidism, but not so much that we make them hypothyroid, and now we have to give them thyroid hormones. Okay, while this kid is in this hypermetabolic state, our goal is to decrease that, to not do anything that's going to make their metabolic need even higher. So we're going to avoid vigorous exercise. We're also going to try and keep them in a quiet, unstimulating environment. So calm, quiet room, no running around, nothing that's going to further increase their metabolism that's going on. And here's that picture of that exophthalmos, the protruding eyes that you get with this. Hypoparathyroidism. This is a decrease in parathyroid hormone, which is responsible for calcium primarily, homeostasis of calcium. If you decrease this, you decrease your calcium in the blood. If you decrease your calcium, you increase your phosphorus. So our treatment, our goal is to maintain normal serum calcium and phosphate levels. The treatment is vitamin D. Some of the symptoms this can, before it's treated and maintained, is unexplained seizures, irritability, you'll have GI symptoms, and tetany, that's muscle cramping. Now hyperparathyroidism, this is really rare in children, but you would have the opposite. You would have elevated calcium, which would give you decreased phosphorus, and you would need to find what the cause of this is and treat the underlying cause. Chronic adrenocortical insufficiency, Addison's disease. This is also quite rare in children. This would be from the adrenal gland, and usually it's from a tumor, a lesion, something on it, but it can be idiopathic, so sometimes we don't know the cause, but usually there's going to be a tumor or some sort of lesion. Now the treatment is to replace the glucocorticoid steroids, cortisol being the one in the body, and also the mineral corticoids, aldosterone being the one we're going to replace. And remember, you have 3 different corticosteroids here. There's also the metabolic one. So this is affecting the glucocorticoids and the mineral corticoids. Okay, during a stressful situation, the child's needs may go up. We're already replacing these corticoids, but we may have to very significantly increase the dosage during any sort of an acute crisis, and illness is one of, that's a stressful situation for the body. Now, if we give too much steroids, we see Cushing's syndrome. We're going to get excessive hair growth. We also get this very round moon face, large pendulous abdomen, poor wound healing, which also goes with elevated blood sugar, fat, red cheeks, bruising, red abdominal striae, that's stretch marks, bruises, and weight gain. And I think there's, nope, not a picture of that. This is where I'll stop.